Welcome to the Bennington Area VNA and Hospice News and Information Show. I'm Marc Miele, Marketing and Fundraising Coordinator for the Bennington Area VNA and Hospice, also known as BAVNAH. In October of 2014, BAVNAH was purchased by the Rutland Area VNA and Hospice. Although we are no longer part of SVMC, we still work collaboratively with the hospital to ensure the highest quality patient care throughout Bennington County. BAVNAH is a Medicare certified home health and hospice agency. What that means is we are certified by Medicare to provide services to individuals in their own home. We are a nonprofit VNA and hospice serving Bennington County. How that differs is we are governed by a volunteer board of directors, and all money goes directly back into the services offered to the community. Our services include nursing, therapy, social work, hospice, and community clinics, all of which keeps individuals safe and comfortable in their own homes. This is a series of shows that will inform you of news, information, and coming clinics, as well as events provided by BAVNAH. Today, with us today is our new Hospice Director, Nicole Moran, and we're going to talk to you about hospice because November is National Hospice Month. Thank you for being with the show
You're
with
welcome.
us today.
Thank you for having me.
I'm a little bit tongue-tied this morning, so obviously you have nothing to be nervous about whatsoever. So, Nicole, would you mind taking a couple of minutes? You're new to the agency. You want to take a couple of minutes and just tell us who you are?
Sure.
Okay.
I'm actually not new to the agency.
Right.
I worked for Rutland Area Visiting Nurses in 2006 and 2007 as a hospice nurse case manager.
Mm-hmm.
And left the agency to pursue management. So I had a drive to do that, and I didn't see a lot of opportunity with the visiting nurses. So I went back to the hospital and pursued my master's degree in nursing with a focus of patient care administration.
Oh, fantastic.
And have worked primarily in acute care settings and intensive care units and progressive care units both at Rutland Regional Medical Center and also at Dartmouth Hitchcock Medical Center. But I came back to VNA in June of this year, so I've been here a little over 3 months as the director of the palliative care and hospice program for Rutland, Dorset, and Bennington.
So you've got quite a bit on your plate.
A little bit, yeah.
Yeah.
We cover a lot of area and a lot of different aspects of care as far as end of life services that we provide to the community. So a lot going on.
Well, in your role as hospice director, I mean, what for somebody who might not have a good understanding as to what that entails?
Sure.
What do you do on a daily basis between three places?
Yeah, on a daily basis, I'm responsible for the day-to-day operations of our hospice program. So, and our palliative care program, and also we have a supportive care program. 3 different things, but all focused around quality of life at the end of life for patients and their families. We really gear our hospice program around supportive care and symptom management. Hospice is something that I think people tend to get a little afraid when they hear the word, and are not really sure what it is. So if I may kind of describe that.
I was just going to ask you for people who might not fully understand what hospice is.
So hospice is a service provided primarily through Medicare. First Medicare hospice benefit was in 1983. And it is a multidisciplinary team approach, meaning multiple different areas are working together to provide symptom management and comfort care really geared around the patient's goals and how they want to live whatever time they have left. So it's all about family support and patient support and really working with them to identify what their goals are and manage their plan of care to make that happen. We address issues as far as physical, social, emotional, and spiritual. When I say we're a team, it's nurses, social workers. We have a lot of volunteers, which are probably one of our best assets that we have in our program. We have our spiritual counselor, a bereavement counselor, And we can also utilize home care aid services, homemaker services, physical therapy, occupational therapy, everything in order to get the patients where they want to be. So we work together very closely.
So your hospice patients would be who?
So our hospice patients, in order to be eligible for hospice, their physician needs to certify that they are terminally ill, meaning they have 6 months or less to live.
Okay.
That doesn't mean in 6 months, if you sign on to hospice and you're still alive, that you are no longer eligible. It just means it's kind of a guess. We have no crystal ball. Everyone has their own expiration date, so to speak. So physician has to certify that you have a terminal illness and that you have a life-limiting disease, and then the patient needs to elect hospice benefit through their Medicare or their Medicaid or private insurance. They're all, we can utilize them all under our care. But what they are saying when they sign on to hospice is that they are no longer seeking any sort of curative treatment for their disease process.
Okay. So, and I know we're going to talk about palliative care in a little bit here. What if somebody is on hospice and maybe is it possible that there might be a new experimental type drug and they say, I want to try this and see if that will either help slow down the process or maybe halt it, or do they have to do something different at that time, or can they still stay on hospice?
Sure, that's actually a very good question. At any point in time under the hospice benefit, the patient may revoke their benefit and go back onto their regular insurance. If they decide, you know what, I want to try something different, they have every right to do that whenever. And it doesn't make them ineligible in the future. They can sign on again as many times as they need to. We can also discharge patients from hospice if they're showing signs of improvement or they're not showing continued decline. We could also discharge them, but again, be readmitted at any point in time. Under the hospice benefit, we get 2 90-day election periods to begin. So we have 180 days, which is 6 months. And then after that, we're unlimited 60-day benefit periods. So we actually have patients that have been on for 37 benefit periods.
Oh, wow.
As long as their goals of care are still aligned with end of life and they're still showing that they are qualifying for the benefit, we can keep them on.
Okay.
So.
Now, a lot of people hear hospice and they might think immediately cancer.
Right.
Is there any reason why you can think of that? Is it just more that it was started up geared towards that? Okay.
Primarily when hospice first started, it was cancer patients that were enrolled in the hospice program. Today, we enroll patients with all sorts of life-limiting diseases, end-stage cardiac disease, end-stage lung disease, renal failure, Alzheimer's, ALS or Lou Gehrig's disease, HIV, AIDS. It's much more all-encompassing now than it has been in the past. Actually, our percentage of cancer patients is lower than all the other diagnoses in total.
Oh, really?
Yeah.
Okay.
Yeah. So as long as they are not seeking active treatment for their disease, curative treatment for their disease, and their physician can say that they have 6 months or less to live, then they qualify for hospice.
Now, where can hospice be performed? Anywhere that they call home?
Anywhere they call home. So majority of our patients are in their own home.
Okay.
We do have patients in assisted living facilities, in nursing homes, and we do also provide general inpatient care if needed in a crisis mode. So we provide care wherever a patient calls home.
So even being in a nursing home, they would still receive benefits of being in that home.
Correct.
And then your team would come in as kind of, extra support for
Exactly.
the whole unit together.
Yep.
That's interesting. That's good. I also hear a lot of people say, isn't hospice about giving up? And it's really not.
No,
Even
it's
though, you might not be seeking curative treatment anymore, it doesn't mean that that's what hospice is, and that's, what
Right.
you you try and help out with, you don't seek curative treatment, but you help out in other ways. And what
Sure.
are some of those?
Well, I think hospice is really, it's not about giving up at all. It's more about living. And it's about focusing on something different, focusing on your quality of life and how you want to live whatever time you have left. It's not, saying I'm done. It's more of what can I do to enjoy these 6 months or more or less that I have left, and what are my goals and what do I want to accomplish or do in that time period. And honestly, when we get patients in a good regime as far as their medications for symptom management, pain and other symptoms, they sometimes are more comfortable and able to do more than they could before they signed on to hospice. Interestingly, there are several studies out there, that talk about patients who have been enrolled in hospice versus continuing curative treatment, and the life expectancies are actually very similar.
Really?
Yeah, yeah. So
it's more about, your quality of life than the quantity
exactly.
of time that you may or may not have left.
Yes.
Of course, none of us know when we're going to go, so
Well,
it's-
that's we don't know our expiration date.
Exactly. It's so well. That's interesting to know. So that way, the folks out there can honestly know that it's not, just saying, okay, this is it. It's and the earlier you're on hospice, you find it's better for the patient
Absolutely.
and the family altogether,
Absolutely.
as opposed to maybe the last few weeks or month or so.
And we get patients enrolled at all stages of their disease process. We do encourage earlier conversations with physicians and offering hospice as an option, because the sooner we can get in and get the symptoms controlled and work with them to develop goals, the more time they're going to have to be doing those things that they really truly want to do. But we do admit patients who are pretty far advanced in their process, and it's really focused on keeping them comfortable as they are actively dying. But we do both, and they're both very beneficial for the patient and the family. And I didn't say this earlier, but I will say it now, that hospice is probably the most rewarding work I have ever done. I mean, I've worked in an ICU environment, as I said, and it's rewarding, but in a different way. I think that we enter these people's homes and their private lives, and they're very welcoming to us, and it's a very special time. Even though it's scary and it's uncomfortable, it's a very special time to be a part of, and it's just, you feel very good about what you do.
Well, let's switch gears a little bit. We talked a little bit about hospice. So I hear
Yes.
palliative care. So what is palliative care? How does that differ from hospice?
Okay. Palliative care is fairly new, up and coming. What it really is very similar to hospice care. It's focused on quality of life and symptom management. However, these patients are still seeking active treatment for their illness.
Okay.
So it could be somebody who qualifies for hospice. They have a life expectancy of less than 6 months, but they still are seeking treatment.
Okay.
I like to tell people that hospice is always palliative care, but palliative care is not hospice care, because
Gotcha.
there is that difference.
So they would continue seeking the treatment.
Yep.
It would just go on until such point that they might decide themselves, okay, time to go to hospice.
Right.
Okay.
Right. And one of the major differences between palliative care in the home and hospice care is, with hospice, you don't have to be homebound. So you can leave your home at however often you would like to do whatever you want. But with palliative care, under the home care regulations, you have to be homebound. So that is sometimes a difficult barrier for people to get over with palliative care.
I could understand that. That might get
Yeah.
a little bit confusing for, somebody who might not know
Exactly.
the difference, because obviously you work in this field, you know what to expect, whereas somebody else, this is
Yeah.
the first time they've ever had to deal with this, so they wouldn't quite understand. I
Right.
wouldn't understand.
Right. And with the palliative care patients, they receive very similar services, with the exception of volunteers, bereavement, and spiritual support. So they have a little less that they can receive within their home.
So somebody could go into remission. They could be in palliative care seeking treatment.
Yes.
or they could be in hospice and start to go, have you ever seen somebody from hospice go into remission of any kind, or?
Oh yeah,
Yeah.
yeah. We see, and it's a lot of times, they stabilize because we put them on on hospice services, and we are managing their symptoms effectively, and they have aids and whatever else they need in their home to be successful, and they end up doing very well and kind of plateau for a while. And so we'll discharge those patients either to home care or to palliative care, with the understanding that if they ever do decline again and want to be back on hospice, that we can readmit them. And we have had that case several times. So
Okay. Well, it's can be fascinating in a scary situation like that to know what kind of support system there is out there in the community, and sometimes people just don't know about it at first. You work with the physicians, you work with the families, you work with everybody who's involved with that particular patient. So although the nurses might not, the nurses would be there to talk to the family members about, certain things, but you also said you have volunteers.
yes.
And you also have bereavement counselors, and you have, a whole gamut of a support system available to patients. What do we'll just touch base quickly on the volunteers. What kind of services would they offer somebody in hospice?
So our volunteers can function in a lot of different capacities. They can provide simply companionship to the patient and or the family. They can provide hours of respite so that family members who are doing caregiving within the home can get out to go grocery shopping or just for some time away. We have Reiki volunteers who come and do this.
Yes,
so
I do know Reiki.
So they have Reiki volunteers who come and do that. We also have in the Rutland office a Dinners with Love program, which I don't believe is down here in Bennington.
I don't think yet.
Yeah.
No.
So, but that's a great service that we provide to families in the community and patients, to provide them with a meal once a week, delivered by a volunteer.
Oh, nice.
We do have some volunteers that provide transport if needed. We'll drive patients. We have singers that will come and sing to patients, and I'm hoping to begin hopefully a pet therapy volunteer program as one of my goals for this coming year. So always opportunities, and they're a great group of people, and we actually are doing a training right now in Bennington for volunteer training. We do that two times a year, and then there's one coming up in Rutland in October 15th. So if people are interested in volunteering, they could always call one of the offices and we could hook them up. But it's a great thing that we provide for patients. So,
as long as we're on that subject here, the volunteer program to become a volunteer, how long is the course?
I'm not specifically not sure. I know that it's several days of training. I think it's like 3 hours a day, I think over a 6 or 8 week period. So once a week. But it's pretty comprehensive, and they go over all the aspects of hospice services, and it's very intense. I did it back in 2006 and 2007. And it's a great training program. And if anyone is even interested in doing it, they should reach out for that.
And I used to work with volunteers all the time, so I know it's a very rewarding process for people who want to give back, or maybe, a spouse of somebody who's passed away and received those services. They kind of want to give back, so they like to go into the homes, and they can offer some sense of understanding as to what the individuals are going through, because they've often seen that themselves. And the people that are down here, the singers, that's the Serenity Singers?
Serenity Singers, yes.
And that's available for hospice patients, so they would come into wherever the person calls home, and they would be able to sing anything pretty much?
Anything the patient would like.
That's nice.
Yeah, yes, so.
Great, so they could go in there and just sing a little rock and roll, or a little bit softer, or a little bit.
Exactly.
Yep. I've heard them sing before, and it's quite the group. They're wonderful people, and they really, really believe in the program, and they want to offer whatever that they can to to the people that are out there that are needing services as well. So if somebody is seeking this, I know you said that it's Medicare, correct? I get Medicare and Medicaid mixed up
Yes,
sometimes.
it's under the Medicare hospice benefit, under Medicare Part A.
Okay.
But also in the state of Vermont, Medicaid has a hospice plan, and so does most private insurers as well. So, and we provide services regardless of the ability to pay. So if there was somebody that needed hospice services or palliative care services, we would not turn away from them if they were unable to pay. We would provide the service that they need.
And that's one reason why we often have fundraisers to help
Correct.
out with hospice.
Yes, correct.
We had one the other night
Yes.
for a Rutland location. We've got one coming up in January called Bowling for BAVNAH Hospice,
Yep.
which is at the Bennington Lanes, and that's on January 24th?
Yes.
Yes, January
Yes.
24th. So people who are interested in helping that out, you actually can call me. 770-1634. Sign up a team if you want to be a sponsor, and all the proceeds are going to the Bennington Area VNA and Hospice program. So all the money that's made here in the community is going to stay in the community as well, and it's going to help the patients that are out there needing services of hospice to be able to receive those benefits, because it is something that is very much needed for help. And I just had another question that popped into my head, and I didn't write it down, so it escaped my mind.
That's okay.
What is the turnaround time? Let's just say a doctor sends in, I'm assuming it would be a doctor referral that would come into the office.
Sure.
What's the procedure at that point in time? You would send out someone to do
and
a
the hospice nurse would go out and do an evaluation or an admission visit.
Okay.
Usually within 24 hours of the referral, depending on the acuity of the patient. So if it was somebody who was more actively in the dying process, we would probably expedite that. If it was somebody who was fairly stable and maybe the family didn't want it for a few days, we could push it back a few days. It's really based on the patient need, how urgently we need to get in there. If it's a same-day admission, we try to accommodate that as well. So
it'd be very quick that all of this could happen. They could,
Absolutely.
go on to the services and just start receiving all of that support.
Yes. Yes. I'm just add on something right there that I forgot to mention before, as far as hospice services. The other things that we do provide for patients, any sort of medical equipment that patients need in their home, are covered through the Medicare hospice benefit. So hospital beds, oxygen, walkers, anything they need to be able to stay in their home. We have contracts with local facilities that work with us to provide those equipment for them. And then also any medications that are related to their diagnosis or that are for comfort are also covered under the hospice benefit. So
that's good to know too.
Yeah.
There's a lot of facets to the whole program that a lot of people might not know or understand that are available to them, and it's as simple as picking up the phone or talking to your doctor about it.
Correct.
And then going from that point on. And just because you ask for hospice or inquire about it does not mean that you absolutely have to go on it. Somebody could just call the person up or go out for a visit, sit down with them and their family and discuss with them what the options are.
Right. Exactly. And we do visits like that, evaluation type visits to assess what the goals are of the patient and the family, and if they're in line with the quality of life and symptom management, then we would admit them. If not, then we could recommend them to other programs, and that's the good thing about starting that conversation and getting us in the door to evaluate and to see what would most benefit that patient and that family for what their goals are. And maybe it's not hospice, maybe it's palliative, or maybe it's home care, but at least gives us a chance to start talking about it, and I think that's the most important step.
And it is true, because I have often heard from survivors of patients who have often said, I wish I had started the process sooner.
Yeah.
there's just all that unknowing, and sometimes just having that extra support system can take a whole different weight or load off from the people who are working with the patient.
Sure.
To be able to know that, if volunteers, okay, Nicole's coming over to my house today. I'm going to be able to step out for a half hour. I need to get my hair cut. I need to
Yes.
go grocery shopping. I need to do this, but it's nice to know that I can leave my loved one in Nicole's care for that half hour and not have to worry about, what's happening.
Yeah, exactly.
I think looking into, being a volunteer, hospice provider is something that I'll end up doing.
Yeah.
So it's
Good. We'll take you.
yeah. Is there any specific kind of life that would be qualified for being a hospice volunteer?
Anybody that has any interest in end of life care, end of life services that are provided, somebody who's compassionate and caring and willing to be with a person during this time in their life. And some people aren't appropriate for that, and that's fine. But those people that are, we definitely welcome them. So.
And the individuals that are going into the homes, they are registered nurses. Are they, personal care attendants if they're on a different program?
Yeah, we have registered. All of our nurses are registered nurses.
Okay.
We also have they're formally trained the bereavement counselor and spiritual counselor. We have medical social workers, and we have licensed home care aides and homemakers. So they all have gone through aggressive background checks to work for our agency. So we don't let anybody go out into the home that we wouldn't let go into our own home.
Right.
Basically.
And then they go through a whole training process with
Yes.
RAVNAH, DAVNAH, and BAVNAH, as I remember
Yes.
very well too.
Yes, they do. They do. Very involved orientation process.
Yeah. So that's another relief for some people who might be a little bit alarmed about, okay, I'm all alone. Do I want to stay in my house by
Right.
myself? Do I want to move to a facility? I don't know who might be coming in. It's a comfort to know that they've been through a lot of
Yeah.
training and a lot of care and education to be able to get to that
Yes.
point.
And we try to keep the people who are going into the homes consistent as much as possible so that people aren't seeing a lot of different faces week to week. We try to keep the same people going in so they can build relationships and develop trust as much as we can. Obviously, people take vacations and people get sick, but as much as possible, we try to keep the consistency with the caregivers.
And to that end, too, you all share your notes with one another as
We
far as
do.
progress or decline.
That brings up another important point. So we, as part of being a multidisciplinary team, we meet every week, and the patient's plans of care are discussed, and we talk to our medical director at that meeting and everyone involved. And if there's something that needs to be changed or new medication, new equipment, we can talk together about it as a group and make changes to the plan of care right then and there with the doctor. And that happens every week, actually in Bennington every Tuesday. So,
Which is one reason why I'm glad that you were able to join me
Yes.
today. I was able to steal you away from your
you
busy
stole me
schedule.
away. Yes.
Well, we could sit here and talk a lot more
We
about,
could.
about hospice and
Yeah.
palliative care and the services that are provided by BAVNAH, but we're just about out of time. So I want to thank you very much for taking time out of your day today to
You're
join me
welcome.
here. And I want to thank you folks for watching. If you have any questions, please call our office at 442-5502, or you can visit us on the web, which is www.bavnah.org. And don't forget to like us on Facebook. And thank you very much for
Thank
watching.
you.